Hello, my name is Jennifer Stevens Lapsley, and I'm a professor at the physical therapy program at the University of Colorado and also the director of the Rehabilitation Science PhD program. I also have an appointment at the Eastern Colorado Healthcare System VA Medical Center. I'm going to be talking about a multi-component telerehabilitation program for medically complex older veterans. So to set the stage for this intervention, let's start with a biopsychosocial framework. Under the category of biologic factors, older veterans have multi-system decline, meaning more medical comorbidities, greater weakness, and higher rates of being overweight and obese. When we consider the psychosocial or the psychological factors, self-efficacy is an important one from a behavioral change standpoint. Furthermore, approximately a third of veterans will have a mental health condition, and veterans are 4 times more likely to have PTSD. And then when we consider interpersonal factors, we know that about 50% of older veterans report loneliness, and we suspect a high incidence of social isolation. And of course, we can't ignore the elephant in the room, which is the COVID-19 pandemic, which has contributed to decreased physical activity, and the consequences are greater for this vulnerable population because they have a lower baseline physical functional level to begin with and more medical comorbidities than age-matched civilians. So it's important to consider all these factors and how they relate to one another. So our telehealth program is designed to address and or measure the multitude of factors which impact physical activity and quality of life. We're directly intervening on biological factors such as muscle weakness by implementing a progressive, high-intensity rehabilitation program. Our previous work demonstrated the feasibility and safety of this approach when used in medically complex older adults in skilled nursing homes, as well as during home health therapies. The current program is identifying how to adapt this approach for delivery via telehealth. We're also including biobehavioral interventions to directly intervene upon self-efficacy and readiness to change to support improvements in daily physical activity. Because exercise has positive benefits on mental health, and mental health can also impact outcomes, we're measuring the mental health symptoms throughout the program, but not directly intervening on mental health. A unique element of the program is the addition of group telerehabilitation and gamification of the sessions. Our goal with this approach is to intentionally engage veterans in their rehabilitation and with one another to reduce loneliness and social isolation. Finally, we've integrated various technologies to support care delivery and behavior change that I'll describe here. So here's an overview of the different technologic adaptations and supports that we're using for this particular study. We're conducting all telehealth visits through secure video conferencing. We're using the Fitbit or another wearable if desired by the participant, as well as text messaging and data sharing through an app to support behavior change and program engagement. The Fitbit helps participants track daily step counts, and this helps with self-monitoring and setting weekly goals. The text messages send a motivational text via a program called Annie, and the text messages also prompt individuals to support behavior coaching. So the sessions that we have with the behavioral coaching are enhanced by these prompts and these reminders. And the text messaging also allows for two-way texts to gather data, such as daily step counts and falls. We're also using the data sharing app that allows us to sync the Fitbit and share the activity data with the therapist. And an important feature of this app is that once it's set up, the participant doesn't need to use it or even open the app, although it's preferable that they engage with it to help them track their progress. Finally, we're connecting our participants with their electronic medical record and their providers by setting them up with their patient portal. In this case, it's called My Healthy Vet. So let me give you a sense of these OneWay text messages. Annie is the name of this particular feature. And so Annie will say, "Hi, it's Annie. Today we'll ask you to share your weekly goal during the group session. We encourage you to write it down." Or Annie might send a message of encouragement, or a message supporting behavior change, such as committing to physical activity and adjusting to a new routine can be a challenge. To help, write down something positive that you get from being active. And Annie might also send prompts for the group sessions. Write down the progress you've made towards your goal, Think about what helped or prevented you from achieving it, and consider sharing it at the group exercise class. There's also two-way text messages where we're asking for a response back, such as step counts. So the individual in this case would enter the number of steps they took and get a response if they achieved their goal that's positive. And maybe if they didn't quite hit their goal, but they made progress, a more tempered response. Keep working on your steps. Activity can help your pain and mood. And if they really undershot their goal, they'll get a response of this nature. It seems you weren't very active today. Is everything okay? Please contact your provider if your health status has changed or you're having difficulty walking. They also have a weekly fall check-in. So did you fall in the past 7 days? And if they didn't, that's great to hear. And if they did, a message back to talk to their provider if they need to. So the biobehavioral portion of this intervention is really important because we're targeting sustained physical activity. We're trying to empower individuals to be able to continue to be physically active beyond when this program ends. And so if you're familiar with motivational interviewing techniques, we use them to help participants develop skills for things like self-monitoring, problem solving, action planning, and goal setting. So we also have group telerehabilitation sessions, and the goal here is to increase patient engagement and connection with other veterans. So we intentionally engage participants in a different manner since the online format lacks the spontaneous conversation you get with an in-person group therapy class. We start each session with an icebreaker question, and the latter sessions we use questions related to the biobehavioral skills they might have learned, the skills that they're using to support behavior change. And these include things like sharing their weekly goal and discussing their plans for continuing activity after the end of the program. Each group session involves 4 different portions: a warm-up, some strength training, a scored workout, which is part of our gamification so that people can feel like they're competing against themselves and potentially others in order to improve their capacity and their exercise throughout their exercise program. And then there's a cool down phase. So provider concerns about patient safety are a frequently reported barrier to providing telerehab to medically complex older adults. Our team has developed a number of safety procedures to mitigate risk and anticipate complex patient needs. For example, each participant receives a patient safety checklist. This checklist they'll review it with their physical therapist during their pre-visit orientation, which is a visit that occurs before the physical therapy evaluation. And the patient safety checklist is then on hand for every session, both group and individual, as a reference. So the safety expectations are made clear and the safety processes are standardized to aid in emergency planning if needed. The checklist also has provider contact information and important clinic phone numbers should the patient require assistance. And there are also environmental safety items that are included, such as scanning the exercise area to make sure it's free of tripping hazards, or having a chair accessible in the exercise area for rest breaks, or placing medical equipment close by for vitals monitoring. Personal safety items include recommending that the patients have their phones accessible in the event of an emergency or lost video connection, and ensuring that assistive devices are used and available during the PT sessions. Also, we have them, it's important to have the patient inform a friend or family member that they're exercising that day. The treating therapist also verifies the patient location, phone number, and emergency contact at every visit. This allows for standardized processes, and in the case that emergency services are necessary, they could be contacted quickly. So there's also a medical safety checklist that allows us to reference vital signs, and we monitor vital signs pre, post, and during exercise. This is a small table with the American College of Sports Medicine guidelines, which both the patients and the providers can use. Our providers also educate patients on signs and symptoms that would merit emergency services, or a face-to-face follow-up, or might mean that exercise is contraindicated that day. Ultimately, the provider must use this constellation of information to determine if the patient can exercise that day. While many clinical interventions can be conducted via telehealth, CPR cannot, and our program is pushing the envelope with progressive exercise, so careful monitoring of vitals and adherence to these safety guidelines is essential. To date, I'm pleased to report that our program has reported no adverse events. A sample of exercise progressions that we typically use can be seen above. For example, if a patient is able to perform 8 quality repetitions of a mini squat with countertop support or chair with minimal exertion, that's considered a level 1 exercise, then they would be appropriate to progress to level 2, which would be a mini squat without upper extremity support. Level 3 would involve holding a weight against their chest, and adjusting the weight is where the treatment team can get very creative in the telerehab environment. For example, the physical therapist can have patients put canned goods into backpacks to wear during their activity, or fill empty laundry detergent bottles with water to serve as hand weights. This is particularly convenient, as 2 cups of water is approximately equal to 1 pound. Our level 4 progression in this case would be a squat with weighted overhead press, which is essentially a dynamic strengthening exercise. Group physical therapy sessions have 2 staff members involved in safety and monitoring: the lead physical therapist and an assistant. Vitals and subjective history are taken by an assistant via phone call prior to the group sessions. Participants also use hand signals to communicate any need for assistance during the group sessions, and the extra staff member is able to support and respond to them quickly. So we're in the early stages of this work, but we've already learned some important lessons. Some of the benefits and facilitators of the program are that the group sessions really do help improve motivation and create a sense of support. These are some quotes we've received from satisfaction surveys and the text messaging platform we're using. Many of the participants have also noted that they enjoy the two-way text messaging when we are asking them about the number of steps taken daily, because it increases their accountability when they know they're going to have to respond with their step counts later in the day. Some of the challenges we've encountered revolve around learning new technology. We found that even if participants are comfortable with their personal devices, including a desktop computer or a smartphone, if we provide them with a new device like an iPad, there's a learning curve, and often the participants want to go back to the technology they know and are comfortable using. When it comes to the end user experience, for everyone it's going to be different. So far, among our participants, they have each required a different level of assistance to help them get set up and learn the technology. So everyone has slightly different problems and different ways to solve those problems. While some of the workflow examples displayed here are specific to the VA, like the consult specifics, the generalizable elements are that you need to identify the technological skills of the participant as well as the equipment necessary. You need to secure that equipment, and you need to conduct a pre-orientation session for training and tech setup. We've learned some tricks, though, and some things that we benefit from in terms of the use of technology. For example, when we're demonstrating exercises that we can't do in person, we can share our screen and play a video demonstrating exercises. We can also consider disabilities differently than what we would use typically in terms of in-person care. For example, it's helpful to wear high contrast colors and avoid busy backgrounds for individuals that have visual deficits. Or if someone has an auditory deficit, it's helpful for the provider to use a microphone headset, and for the patient to also have headphones or an external speaker to minimize some of the background noise. To improve the ability for everyone to hear, it's necessary to mute all the participants in the group sessions, and this makes it difficult to check in with patients or for them to voice concerns spontaneously. To accommodate this, we've developed hand signals to indicate when they need help, either repeatedly patting the head or tapping the nose. And this is also another important reason why we need 2 people during the group sessions, because the assistant can recognize the signal and can call the participant to check in without disrupting the flow of the session. Our providers have also found the technology to be helpful for remote monitoring, both synchronously and asynchronously. The Bluetooth-enabled monitoring equipment, such as a blood pressure cuff and a pulse oximeter, will display readings on the screen for real-time assessment of vital signs. And our provider dashboards can help us monitor patient progress. For example, the text messaging app allows us to see if the messages are being sent and returned as intended, and what their step counts are on any given day. We can change the message settings based on participant feedback, and we can graph those step counts to monitor trends over time. While we have much to learn, we have been fortunate to have this opportunity to launch this work with the support of the Office of Connected Care. So this is the team that's responsible for the Telerehabilitation program that I just described, and I want to particularly thank the Office of Connected Care and Michelle Rousey and Megan Olivos for their contributions to this program. We also have a number of co-investigators that are involved in this work, as well as the Office of Connected Care has really been instrumental in providing some resources. Brian Vetter in particular has been really helpful with the Annie app. So thank you very much.